Well, good morning, everyone. Let me add my thanks to you, Secretary, for joining us. You bring really a wealth of experience to the role in a way that, at least in modern times, I think no secretary has brought as a leader in healthcare delivery in a number of different diverse settings, including my own home. So thank you for that. We'll jump right into the questions that we talked about, and we'll see where that takes us. So first, and we were just talking about this, the last 6 or 8 months you've been consumed with managing the crisis related to the Steward Healthcare bankruptcy. Steward's a for-profit healthcare delivery system in Massachusetts and in multiple other states. And that bankruptcy proceeding has led to hospital closures and reductions in services, and it's led to questions about the role of government in overseeing for-profit healthcare. And at the same time, we recognize that there are for-profit entrants into healthcare that have increased accessibility, increased some capacity, and often at an attractive price point. So how do you think about that balance? It's much more nuanced than a simple yes or no answer.
Okay, so you told me I can't just say yes or no. So, hi, good morning, everybody. I'm glad to be here. I think nuance really is an important word, and it's particularly nuanced in a state like Massachusetts, where private investment in life sciences has really created an industry. We're probably 5 miles in an hour in traffic from the life science hub of the world. And as we think about investments in healthcare and investments in innovation, getting the balance right between people who are appropriately disrupting our industry that needs some disruption versus people who are kind of just vacuuming it for profit. And I think we have examples of both in our state. And as Secretary of Health and Human Services, finding a middle ground through those kinds of challenges is really important. The other thing I would say is that when something like the Steward bankruptcy happens, we end up with lots of very well-intended people wanting to do something. And so you end up with a lot of proposed legislation, as an example. And what's the aphorism? Marry in haste, repent in leisure. I think if you legislate in haste, we could repent in leisure. So we're trying to find, I think everybody across our state government, the investor community, hospital leaders like yourself, are trying to find the right place for investment capital in our industry that we desperately need, and our ability to continue to provide services that may never generate a surplus or a profit.
So maybe I could ask you a follow-up on that. So, there's been a big sort of negative push as a result of the Steward fallout, and yet we recognize that there are also lots of positives that the for-profit entrants into healthcare delivery have brought, whether those are purely for-profit or whether they are joint ventures with nonprofit. And how is the administration thinking about the oversight that will be needed to sort of support and maintain the good while controlling the bad?
Yeah, I think the question, I don't think there's a one-size-fits-all answer. I feel like I'm in politics. I have this really strong temptation to pivot away from this question, but I will try to answer it directly as I can. I think that I think we need guardrails. I think the governor would say that what we saw with Steward was an extreme example. This is an example of people who have. This is a system that I'm not sure we could have written a law to prevent what happened. But there are a couple of foundational challenges that we faced with the Steward bankruptcy that I think we would seek to avoid. It is really hard to convince somebody to acquire a health system where you don't own the land, you don't own the building, virtually every piece of equipment is leased, and oh, by the way, the doctors are for sale as well. I mean, you passed. And so I think so I think there were some structural challenges that were unique to Steward that we should never repeat.
Well, let's pivot to a topic that is also hard to solve, but one where there's perhaps less controversy, and that is health equity. So you and Governor Healy have made health equity and equity in general really a foundational block of the administration. And as it relates to healthcare, how are you overseeing the investments that are being made by the administration here in the Commonwealth to ensure the outcomes that we want? And what are the lessons learned there?
Well, I think the most important word that you said is outcomes. I think people talk about equity and they kind of conflate in DEI, they conflate in reporting, and what we really need to do is improve the health outcomes for the people we serve. And Governor Healey's been very clear that equity is, one of her number one policy agenda, and she talks about it both in terms of racial health equity and reducing the disparities that we see in health outcomes by race and ethnicity, and also regional health equity. We live in a compressed geographic state, but we have rural areas, and part of the Stewart challenge was some of the places where the hospitals were non-sustainable were in rural areas. And if you look across our country, I think it's a third of the rural hospitals closed last year. So we have an access problem, we have an equity challenge, and I think it's going to require really innovative solutions. Fortunately in Massachusetts, we don't have any maternity deserts, but you look across our country and you see those everywhere. And if one of our initiatives is around maternal health, and so imagine that in a situation where you're in a county where the last OB has just retired. And so for us, the first focus really is identifying the challenge. You can't fix what you don't see. So we are rigorously interrogating our results through the lens of race and ethnicity and region. And I think that's the first thing we need to do. The second thing we need to do is focus. And that's very hard to do in government. So our health equity across our secretariat work has been focused on 10 regions. If you're based on those with the worst outcomes, if you're the 11th region and you're a legislator for that area, you want your region on the list, but we had to say, no, we're going to focus where the problems are the biggest. And then we focused in two areas. One I referred to, maternal health equity, and the second is cardiometabolic disease. And interestingly, we're trying to do that work from the community forward, as opposed to coming in with yet another government program that may or may not work. And so our work in Springfield is going to be different than our work in New Bedford or in Lawrence, because we're going to be guided by what the communities tell us their challenges are. And we're really sort of thinking about this in a place-based investment way, because we have, I have this mental image of people lining up for all our programs and services, and what if we just cut across that and served a family, or served a street, or served a neighborhood? And so we're trying to find different ways to address these challenges, because there are not infinite resources.
Well, thank you for that. I'm happy to hear that our approach at Mass General Brigham in health equity is following a very similar path to the one that you're leading at the level of the Commonwealth. We have learned to focus. I think that's an important lesson, and you underscored it really well, and our quality leadership has really taught our whole leadership team that over the last couple of years. And we also are focused on maternal health and on cardiometabolic, which translates to heart disease, blood pressure control, kidney disease, and diabetes control.
I'm glad you didn't ask me to explain that. No, sorry, kidding.
So one question I'll ask, though, is that in our discussions around health equity, and you and I have talked about this before, it seems quite clear that within the healthcare delivery system, we can only achieve so much. And until we address more broadly the social determinants of health, housing insecurity, food insecurity, those sorts of things, which have impact on human health that can't be fixed by how we deliver healthcare per se. So can you say a little bit more about the administration's approach there? It's obviously been a high priority to address those social determinants of health.
Yeah, no, thank you for that. I probably should have mentioned it. One of the things that most of the states, many of the states in our union, Medicaid is a federal and state partnership. And our Mass Health program, our Medicaid program, insures about 2 million low-income friends and neighbors across our state. And as we think about the best way to serve them, clearly the social determinants or the social factors for health or the basic human needs really come to the forefront. So through a waiver process that the federal government allows us to do, the so-called 1115 waiver, we've morphed that over the last 20 years to make it really much more focused on health equity outcomes. And in our waiver process, we have funding for nutrition supports and for housing supports. We are not writing a check for rent, which I think actually some states are doing, but we are supporting people getting out of shelter and into housing. And we are supporting people who could need medically tailored meals because of their complicated medical condition. And so we're trying to find ways, and we're not doing this from the 11th floor of Ashburton Place where my office is. We're doing this on the ground through our accountable care organization process. So across the state, we work with primary care practices, people who are caring for these patients, to invest in those social factors for health that are most important in those communities. You know, it's early days. We're right now sort of in the pay for reporting phase of this, but we'll soon be moving to pay for performance, so that if you have, you know, 20,000 diabetics across your ACO panels, you need to bring down their A1C, not just report on it.
Yeah, thank you. This is an enormously challenging issue that this is where the partnership between the public sector and the private, both nonprofit and probably for-profit sectors, really have a chance to make a huge impact. So let's talk a little bit about the health equity challenge, that maybe the other unexpected challenge that you faced as secretary, and that is the impact on the significant migrant population that's arrived in Massachusetts during Governor Healey's administration. How have you approached the need, not just for health care, but for housing and education and other social services, and what are the lessons learned there, and you know, where are the opportunities for improvement as you manage this process that's evolving?
That's a tough one. It's a challenging problem. I think it's a problem that our planet faces when we think about migration. If you think about what we experienced over the last couple of years in Massachusetts, it's probably a microcosm of what New York City experienced, and that's a microcosm of what border states experience. So setting this in context, we've spent a lot of time, a lot of resources, a lot of stomach lining trying to figure out the best way to welcome new people to our state. We need the workforce. I mean, so that's the most important thing. Massachusetts is a graying state. So there are new arrivals bring real economic advantages to our state. It's hard to see that when you're talking about spending $1 billion and you still have 7,500 families in shelter as opposed to a home. And that, the disconnect between what it costs to shelter people and the challenge of housing them in a state where I think we have the lowest vacancy rate of any state in the country. I think it's like under 2%. So even finding a unit, if any of you are looking for apartments to rent, particularly at a low price point, it's really challenging in our state. So you have a compressed housing supply, a great need for people who have made enormous investments, and you know, these are resilient people who've traveled for, in some cases, years. And now they're in Massachusetts, and how do we take advantage of that human capital in a way that's safe and humane and effective? So what we've really tried to do is shift our focus from spending money sheltering people to spending money helping people find housing. And that shift is really challenging. And it takes a lot of resources, and it takes hard conversations with families. And the people who do this work on the front lines, I have so much respect for them, because I think about it in the abstract, but when it's 5:30 on Saturday night and somebody's looking at you and you have no place for them to stay and it's pouring rain and they've got a 2-year-old, that's an enormous human challenge. And there's really strong feelings on all sides of this. And Massachusetts is the only state in the union that is a right to shelter state. So what we've really tried to do is say shelter's important, but it should be brief. It should be non-recurring, and there's one other word for it, brief, non-recurring, and rare. And so that your stay in shelter should not be years, it should be days. But that requires a real pivot to housing. And the legislature passed a housing bond bill. We simply need more units. But until those units come online, the disconnect between our aspirations and the demand for shelter is going to be really, 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 really challenging. The other thing I'd say is that, and this is something that our team wrestles with a lot, is there are people who are in shelter in our state and have needed shelter for a long time. There are about 3,500 families that were always in shelter. That number, not always, but have been chronically in and out of shelter. Large, complicated families, bad eviction history, maybe they can't pass a criminal background check for public housing. Whatever the issues are, there are families that the state will always need to help serve in that way. New arrivers, many of them don't have those attributes. They are resilient, intelligent people who have made the decision we would all make for ourselves and for our family, which is to get out of a country where you simply cannot thrive. And so what we have to be really careful is that we don't sort of make people who really just need a momentary help in a new country, we don't want to make them into kind of chronic human service clients. And so how we work with them has been a learning curve for our teams. So the public health screening is pretty basic. It is not, and people have access to public benefits because they are all, just to dispel the myth, in our country legally. And so we're able to kind of connect people with services, help them get started, help them find jobs. I was I attended a very moving ceremony at one of our state institutions that serves people who are severely developmentally disabled, and we had 9 people who were living in a local shelter who had gone through a training program and had graduated, and they were going to be aides. They were going to start as CNAs or housekeepers in this school. We can't find people to do this work, even paying state wages. And the families came. It was like the Oscars, and there wasn't a dry eye in the house because people were like, finally, I can take a breath. Finally, I can help my family. Finally, my son will see me go to work. It was an incredible opportunity where people with incredible needs were being met on both sides of it, the patients who they were going to serve and the people who were going to do the work. So it was really the highlight of my, as you pointed out, pretty long and fraught journey around new arrivals in our state.
I'll have to say on behalf of all of us, thank you to you and to the governor for the thoughtful approach to supporting this population. And maybe we could just drill down on the healthcare needs of the population, because so many of the families that have arrived have children, which has put a sort of a disproportionate burden on those hospitals and systems that take care of children, which, as you know, is not every health system in the state anymore for a variety of reasons. And how do you think through that?
Well, fortunately, not exclusively, but fortunately, the kids are healthy. And so we've really relied on, Massachusetts is blessed by a network of federally qualified community health centers or community health centers across our state. I think there's 52. And so we've been much more intentional about trying to site shelter locations with an FQHC partner, and the Mass League of Neighborhood Health Centers has really stepped up to help us do that. And so but they face the same thing that all your practices face, which is a shortage or long waiting lists for primary care. So this has put more pressure on that. The health centers have figured out a way to kind of prioritize the new arrivals so they can at least be initially screened. Pregnant moms can get seen, people can get prenatal care, all the things that you would expect an FQHC to do. I think the biggest burden is that there's a lot of trauma in this population. People have been through a lot to get here. And so how we shore up those services, identify people who are at risk, who's, maybe they left their home country 9 years ago and they've just broken. And we need to make sure that we recognize those signs and help people get the help that they need. It's a really complicated problem, and if I had a magic wand, I would try to take it out of the political arena and just try to deal with it as human challenge, but it is so fraught. We have people in, I mean, we're consolidating the sites, but at one point we had people in 300 cities and towns. There's only 351 cities and towns in Massachusetts, so it was really a journey for us as state leaders to try to figure out the best way to keep people safe, but work with the local community, because you're a small school district and suddenly you have 30 children who don't speak English, and you're coming into your school at all different grade levels. How do you support them?
So you've had to take on, we've talked about two, there have been several really unanticipated and enormously challenging disruptors. Let's talk about a hardy perennial, one that you did anticipate and you've thought a lot about, and that is the challenges with capacity and of cost of delivery of care here in the Commonwealth. So, and you've, of course, been a leader in this space for so long, and both as a leader in care delivery and now as on the side of the state government. Mm-hmm. So the evolution of care to less and less intense locations closer to home has been touted as one way to try to bend the cost curve in the delivery of health care, not just in the Commonwealth, but across the country. And with I'd say the catalyst of the pandemic, which catalyzed so many innovations, the ability to take care of patients in lower intense settings, including at home, has given us a new opportunity. So how are you thinking, how is the government thinking, the administration thinking about how that work is going, where the opportunities are to get the right patient, the right care in the right place at the right time across high-intensity locations, lower-intensity locations, or even at home, and that opportunity then to reduce the cost of care delivery?
Yeah, I mean, first of all, I think that your system, I think MGB has really led the way in this, and I really thank you on behalf of the rest of us who are trying to sort through this. I worry about one thing, which is, you just talked about this as care in specific locations. And we talked earlier about equity and social factors, and I think that we'll be much more successful in our journey to keep care in a community, keep care local, keep care at home, if we can support those social factors as well. I mean, the simplest thing is it's hard to care for somebody who's unhoused through this mechanism, which is sort of a throwaway line. But I think that if we, I learned when I worked at Boston Medical Center that we tend to kind of criminalize certain diseases, behavioral health and substance use disorder, and we medicalize poverty. And I think if we want hospital at home or SNF at home or healthcare at home to work, we have to think about the complicated set of social factors that make people safe or not safe in their home. And some of those have nothing to do with their COPD. And I think that's what we have to, so we have to make sure, and I was just reading something this morning that talked about payment for hospital at home, and there's a payment for education, and then there's a payment for technology, and then there's a payment for the doctor reviewing the technology. And I hope that some of the innovators out here can find a better way to build this mousetrap, because if we build it based on, putting a hospital in somebody's living room, I think it's going to fail, because we can't scale it. So we've got to find a way to blend what we know about keeping people healthy in their homes and in their communities and social factors with the very important medical care that we can now deliver remotely.
So I'll pick up on a couple of threads there. So as you mentioned, we are now running one of the largest hospital at home programs in the country. There's probably somewhere between 40 and 60 inpatients, patients who are meet criteria for inpatient status, being cared for in the home with the advanced monitoring that's now available and being visited by healthcare providers in the home. I think that one of the things that we struggle with is ensuring equity in that process. It is easier, of course, to take care of a patient in the home when they have a stable home environment, when they don't have food insecurity, when they have access to technology, when English is their first language. And we're paying quite a lot of attention to ensuring that we're delivering a product that can be scaled across our entire patient population and not actually worsen the the equity gap, if you will. At the same time, we see an enormous opportunity as we take care of patients in increasingly lower intense settings to reserve the high-cost bricks and mortar facilities at our academic medical centers for the most intense care, and that, in the long run, should balance out, I hope, the investment we're making in home care. Does that resonate with you, or do you have concerns? And I guess we're going to finish on this question because we're now seeing negative time on the monitor.
Yeah, my answers are too long, sorry. I think that, so I've done my job, I filibustered, no. I think first of all, it's really, can't fix what you don't see, so it's really important to be intentional about that. The other thing I would say is it goes back to this medicalization. Like, is the service that will keep a low-income person in their home the same thing they would need if they were on one of your inpatient floors at the Brigham or the MGH? And I think we have to really just challenge ourselves to think about that, think about different ways to do this. I think this is a great opportunity for innovation, for disruption. And I would also encourage all of you in the shameless plug mode to apply the same thinking to the human services that we deliver across our state. We have an aging population. We have a tsunami of kids who turn 22 with autism and are kind of dumped into a system that cannot, they've had great care through the education system, and now they're adults, and how do we help them live the lives they're meant to live? There's so many opportunities for us to think about using technology, using predictive analytics, using artificial intelligence, whatever, but there has to be a way to care for people that isn't as capital intensive and as human intensive, and really reflects the care that the people, what they want for themselves, and keep, and sustains agency so that they can make their choice and be healthy. So,
thank you very much, Secretary Walsh, for being with us today.
Thanks, everyone.